Inspect the patient's knees, noting their alignment and any deformities. Note atrophy of the quadriceps muscles or loss of the normal hollows around the patella. Then palpate the suprapatellar pouch on each side of the quadriceps, noting any thickening, swelling, or tenderness. Also palpate along each side of the patella. Identify any thickening, swelling, or increased warmth. Repeat on the other side. If you suspect a small amount of fluid in the knee, look for a bulge sign. First, milk the medial aspect of the knee firmly upward with the ball of your hand to displace any fluid. Next, press or tap the knee just behind the lateral margin of the patella. Watch for a bulge of returning fluid into the hollow medial to the patella. None is seen here. In another patient, there is a positive bulge sign. If you suspect a larger amount of fluid in the knee, check for a balloon sign. To do so, rest the thumb and index finger of your right hand on each side of the patella. With your left hand, compress the suprapatellar pouch back against the femur. Feel for fluid entering the spaces under your right thumb and finger. If you feel it, a balloon sign is present. If fluid is felt, press the patella backward against the femur with your right hand as your left hand feels for fluid returning to the suprapatellar pouch. A palpable return of fluid confirms a balloon sign. None is felt here. If the patient has a history of knee pain, compress the patella and move it against the underlying femur. Then push the patella distally and ask the patient to tighten the knee against the table. Pain and crepitus suggest a patellofemoral disorder. Now flex the patient's leg at the knee to about 90 degrees. With your thumbs, press into the tibiofemoral joint on each side of the patellar tendon.
How's that feel?
Feel along the tibial margins. Tenderness from a damaged meniscus may be present here. Then palpate along the course of the collateral ligaments, laterally and medially. To begin your examination of the neck, inspect for symmetry, look for enlargement of the parotid or submandibular glands, and note any visible lymph nodes or scars. If you see any masses or swellings, palpate them for size, consistency, and tenderness. Next, palpate the lymph nodes. Using the pads of your fingers, feel for the preauricular, posterior auricular, occipital, tonsillar, submandibular, submental, superficial cervical, and posterior cervical nodes, and the deep cervical chain, including the supraclavicular nodes. Note the node's size, shape, delimitation, mobility, consistency, and any tenderness. Normally, some small, non-tender nodes may be felt. Tender nodes suggest inflammation. Hard or fixed nodes suggest malignancy. Now, inspect and palpate the trachea for deviation. Next, inspect the thyroid. To do this, light the patient's neck tangentially from above. Now ask the patient to sip some water, extend her neck back slightly, and swallow. Observe for upward movement of the thyroid gland, noting its contour and symmetry. Identify the thyroid cartilage, the cricoid cartilage, and the location of the thyroid gland. Now watch as the thyroid cartilage, cricoid cartilage, and thyroid gland all rise with swallowing. Watch again. Normally, the thyroid and cricoid cartilages and the thyroid gland rise with swallowing and then return to their resting positions. Check your inspection by palpating the thyroid gland from in front of the patient. As the patient swallows, feel below the cricoid cartilage for the thyroid isthmus. Now move behind the patient and place the fingers of both hands on the patient's neck so that your index fingers are just below the cricoid cartilage. Again, ask the patient to take a sip of water and swallow it. Feel for the thyroid isthmus rising under your finger pads. Move your fingers laterally as needed for the anterior surfaces of the lateral lobes. For a patient who cannot sit up, all of these tests can be performed with the patient lying down. Biceps reflex, triceps reflex, brachioradialis reflex, knee reflex, ankle reflex, plantar response, and ankle clonus.